Hi, everyone. On today's podcast, we're going to talk about the evidence on diagnosing gestational diabetes and using the glucola test. Hi, everyone. I'm super excited to welcome you to this episode of the Evidence-Based Birth podcast. Gestational diabetes is a fascinating topic, and it was one of the first things that people asked me to write about when I started Evidence-Based Birth nearly 7 years ago in the year 2012. We just released a new signature article all about the evidence on diagnosing gestational diabetes and using the glucola test. You can find that at evidencebasedbirth.com/diagnosing-GDM. So like I said, I originally published an article on this topic in 2012. And this year, my research assistant and I, Anna Bertoni, MPH, worked really hard. We spent a long time this year working on this article because this is a very technical topic and the research is very difficult to decipher. So I'm going to start off by defining and describing gestational diabetes, and then I'll kind of summarize briefly what we found about the research evidence on screening and diagnosing gestational diabetes. So gestational diabetes, often abbreviated GDM, that stands for gestational diabetes mellitus, is high blood sugar that develops during pregnancy. To understand gestational diabetes, it's helpful to first learn how your body metabolizes sugar. When you eat or drink carbohydrates, often called carbs, your GI system helps those carbohydrates into your bloodstream as glucose, which we often call sugar. Then your body must turn that glucose into energy. So insulin is a hormone produced by your pancreas that helps deliver glucose from the blood into your body's cells, where that glucose can then be turned into energy that fuels the cell's functions. Insulin can also help convert extra sugar into fat for storage. Now, everybody who's pregnant experiences some level of metabolic changes during pregnancy. In a normal pregnancy, your hormones from your placenta can make it harder for your body to use insulin, and that means you might need up to 3 times more insulin to overcome the increased insulin resistance. Now, when I say insulin resistance, the easiest way to understand that is to imagine as if there was a neighbor, in other words, insulin, who kept knocking on your door, your cell, with gifts of food. And over time, the neighbor had to knock louder and louder to get you to open the door. In a pregnancy that's not complicated by gestational diabetes, it is harder for insulin to open the door, but your own body's insulin response, or the ability to produce more and more insulin, is enough to overcome the resistance. However, with gestational diabetes, there's either too much insulin resistance or too little insulin response, or a combination of both. You can imagine that in a scenario where the neighbor keeps knocking on your door, eventually they're going to give up and take the food somewhere else. In a similar way, when this happens to gestational diabetes, glucose builds up in the blood because it can't get into the cells until it reaches abnormally high levels called hyperglycemia, or high glucose levels in the blood. It's those high blood sugar levels that can cause problems for mothers and babies. Now, research thinks that everybody has a little bit of insulin resistance during pregnancy, and this exists to help move more nutrients to the baby instead of being in your body to promote healthy fetal growth and development. Your body's making sure that the baby is getting enough nutrition from sugar in the blood, even if food was scarce for the mother. You can imagine that this adaptation might have helped us in the past when food was scarce, but most people today have too much food available, including too many processed foods with simple, easily digested sugars. This situation has led to more people putting on extra body weight, which tends to increase insulin resistance and further increases the risk of high blood sugar. Gestational diabetes today is actually one of the most common problems of pregnancy. Using current diagnostic criteria in the United States, about 7% of people who are pregnant have any type of diabetes, including GDM. If we switch to a different diagnostic criteria that kind of had a lower cutoff, you could diagnose as many as 18% of people in the United States who are pregnant as having GDM. Now, there are certain things that can put you at an increased risk for GDM, The main risk factor is being plus size, since the risk of GDM increases with increasing body size. However, someone who is not plus size can still get GDM. About a quarter of people with GDM have a low pre-pregnancy BMI. Other risk factors for GDM include increasing maternal age, having a history of GDM in a prior pregnancy, having a history of having a large baby, having diabetes in a close relative. The main problem with GDM is that it can cause problems. There's one study that I talk about in the signature article. It's called the HAPO study, the hyperglycemia and adverse pregnancy outcomes. It's really the most important research that's ever been done on this topic. And in this study, they followed more than 25,000 people at 15 hospitals in 9 countries. And they found that increasing blood sugar is linked to an increase in poor outcomes, even at levels not considered to be diagnosed as gestational diabetes. The researchers divided people into 7 categories for blood sugar levels at 3 different time periods. And the key finding from this study was that the relationship between the mother's blood sugar levels and the risk of poor birth outcomes was continuous. This meant that there was no specific cutoff where they could say this level of blood sugar is going to cause problems and this level does not. Instead, the risk of having an adverse outcome increased step by step with every small increase in blood sugar levels, even within blood sugar ranges previously considered normal for pregnancy. So in other words, there's no clear cutoff where we can say this is normal and this is abnormal. And this is why there is so much controversy over how to best diagnose gestational diabetes. It really exists on a spectrum. It's not a condition that you have it or you don't. Instead, there's just this, as your blood sugar levels go up, there's a gradual increase in the risk of having adverse birth outcomes. I won't go in depth into the study results. You can read it in our signature article, but gestational diabetes has been linked to higher rates of preeclampsia, high blood sugar in the fetus, needing a first-time cesarean, preterm birth, having a baby that is large for their gestational age, shoulder dystocia or birth injury, higher rates of newborn intensive care, newborn jaundice, newborn low blood sugar, and higher rates of the mother developing diabetes or heart disease later in life, and the baby developing excess body weight or diabetes later in life. So that's kind of the setup to let you understand like what we're looking at, what gestational diabetes is, how common it is, the risk factors, and the risk of adverse outcomes. So next I want to talk with you about screening and diagnosis. These are 2 terms that are often misused or misunderstood even among researchers. Screening means you look at a large or general population and you figure out which individuals are at higher risk of a condition. So an example of a screening test is the glucola drink, which is 50 grams of oral glucose that you drink. Another example of screening could be looking at risk factors, meaning you would check each mother for factors that put them at a higher risk for GDM. On the other hand, diagnosis is defined as identifying whether or not a condition is actually present. The only accepted diagnostic test for gestational diabetes is something called the oral glucose tolerance test, or OGTT. This is typically given with 75 grams or 100 grams of glucose. Another terminology that's important for you to understand is the words universal or selective. So screening tests and diagnostic tests can be universal or selective. An example of a universal screening test would be giving everyone the 50-gram glucola drink, regardless of whether or not they have individual risk factors. A selective screening test would be only giving glucola to people with certain risk factors for GDM. Likewise, selective diagnostic testing means you're giving the oral glucose tolerance test, or OGTT, only to people who are at higher risk for GDM based on a screening. Whereas universal diagnostic testing means you'd give everyone the diagnostic OGTT, regardless of whether or not they have risk factors for GDM. Okay, so now you have a baseline knowledge of what I mean when I'm saying screening test or diagnostic tests. And typically in the United States, it's used universally, meaning everybody is universally screened with the glucola. On the other hand, in many other countries around the world, They prefer the one-part diagnostic method where universally everybody gets the 75 or 100 gram diagnostic test. So they skip the glucola and they go straight to the diagnostic test. This diagnostic test is typically the 75 gram 2-hour OGTT, which requires fasting before the test. It measures blood sugar after fasting and again at 1 and 2 hours after the test. So that's the one-part diagnostic method using the OGTT. The glucola test that's used in the United States is really part of a two-part screening and diagnostic method. So you screen first with the glucola, and if your results are positive, then you go on to do the fasting test where you fast, and then you do the OGTT on a different day to actually diagnose GDM. With that two-part method, after you do the glucola, if you screen positive on a different day, you'll typically do a 100 gram 3-hour OGTT, and it measures your blood sugar after you've been fasting overnight, and then again at 1, 2, and 3 hours after drinking 100 grams of glucose solution. Just so you know, most hospitals set their own cutoffs for diagnosing gestational diabetes. So your chances of being officially diagnosed may differ depending on which hospital you're going to. The two-part screening and diagnostic method is endorsed by the American College of Obstetricians and Gynecologists, and that's why it's so common in the United States. In Canada, they use something a little bit similar. It's called the two-part screening and diagnostic method. They start with the 50-gram glucola screening test, and then if that's positive, they do a 75-gram diagnostic test. It's a little bit different diagnostic test. And that is endorsed by the Society of Obstetricians and Gynecologists of Canada. But most everybody else in the other countries prefer the one-part diagnostic method where you drink 75 grams of the oral glucose tolerance test over 2 hours. And this is the preferred option from the American Diabetes Association. It's also recommended by the World Health Organization, the International Association of Diabetes and Pregnancy Study Groups, the Canadian Diabetes Association, and the Society of Obstetricians and Gynecologists of Canada. So those two Canada groups consider this an alternative option, but they prefer their other option. So as you might imagine, this is getting a little confusing because everybody thinks they should be doing something different. And this just underlies the fact that the best way to diagnose and screen for gestational diabetes is very controversial. The reason why the World Health Organization and so many countries, including international working groups, endorse that one-part diagnostic method with the one diagnostic test being used with everyone is because that test was based specifically on pregnancy and birth outcomes from the HAPO study. Whereas the two-part method using the glucola and then the follow-up diagnostic test was more based on identifying people who have a future risk of getting type 2 diabetes. If we adopt the more internationally recognized criteria for diagnosing gestational diabetes, the number of people who would be diagnosed with gestational diabetes in the United States would probably double or triple. This means more people would potentially benefit from treating their high blood sugar. However, there are also downsides to adopting this path, which is why there's no agreement in the United States on which method to use. Using the universal, everybody does the diagnostic test with 75 grams. Everyone has to fast beforehand, which may be difficult for some people. Also, an increase in the number of people diagnosed with gestational diabetes comes with an increase in both personal and healthcare costs. Once you're diagnosed with gestational diabetes, you face more medical appointments to meet with a registered dietitian, a diabetes educator, or both. And then you must carefully watch what you eat, monitor your blood sugar several times a day. You have to get testing supplies. You might need blood sugar medication and extra monitoring. And all of this comes with significant costs, which are not always fully covered by insurance in the United States. Also, a diagnosis of gestational diabetes can be stressful for some mothers, and mothers tell us that they're worried that their care provider might pressure them into an induction simply because they have gestational diabetes. And we're going to cover induction for gestational diabetes in a separate article. Another reason there's so much controversy on which method should be used to screen or diagnose gestational diabetes is that we don't have a ton of research from randomized trials on this topic. There is a Cochrane review published by Dr. Farrar et al. In 2017. They were able to include 7 trials with a total of about 1,400 participants, and they found disappointing results. The studies on this topic are of poor quality, they have small sample sizes, and they didn't report important infant or maternal outcomes. And because the evidence was so limited, the Cochrane reviewers say they can't recommend one strategy of diagnosis over another. And they concluded that we need large randomized trials before we can establish the best way to identify people who have GDM. There was actually only one randomized trial in the Cochrane review that compared the 1-part diagnostic method using that 75-gram OGTT with the 2-part screening and diagnostic method that used the glucola and then a follow-up diagnostic test. They did not measure any maternal or infant outcomes. They only measured the rates of diagnosis for GDM, and they found that the 1-part diagnostic method does result in more diagnoses of GDM compared to the 2-part screening and then diagnostic method. And this finding has been supported by observational research, and it's widely accepted that the more internationally recognized criteria and method of using just the 1-part diagnostic test with everyone would diagnose more people. A lot of people ask us about alternatives to glucose drinks. The Cochrane researchers did compare eating a candy bar to drinking the glucola. They found that mothers preferred the taste of the candy bar. However, their 1-hour blood sugar levels were lower with the candy bar, which could mean that people with actual GDM could be missed by eating candy instead of taking the glucola drink. Another trial from Mexico with only 30 women compared receiving 50 grams of glucose from food versus drinking a 50-gram glucola. Again, mothers preferred the food to the glucola, not surprisingly, but the studies were too small for us to really get any useful information from them. There's also been several other studies looking at candy. One was in 2015 by Rakusin. It was a non-randomized crossover study, and they used candy twists. They're like strawberry flavored candy, and they had 20 women who were already screened as positive for GDM with the glucola test, and they were going to undergo the 3-hour 100-gram test. And before they went to that 3-hour one, they tested them using this candy method. So they ate 10 strawberry flavored candy twists within 5 minutes and then had a blood draw 1 hour later to measure their blood sugar levels. All 20 women screened positive for GDM with the glucola, and only 11 of the 20 screened positive with the candy twists. Now, the study was small, but it did find that the candy twists had a sensitivity of 100%. It did correctly identify the 2 people who ultimately ended up being diagnosed with GDM after the 100-gram diagnostic test. The researchers felt that the candy twist method did a better job avoiding false positive screenings compared to the glucola. However, this was a very small study. In another study that's widely cited, researchers used jelly beans. They instructed people to either eat 28 jelly beans or to drink the glucola and then take the 1-hour test. And then within 1 week, everyone switched and did the opposite. Mothers reported fewer side effects after the jelly beans, but still 20% of people who ate jelly beans had side effects, compared to 38% of people who had glucola. And the jelly bean test was probably not as sensitive as the glucola drink, although it's difficult to tell because the study was probably too small to tell a difference. In that jelly bean study, interestingly, the researchers sent that specific brand of jelly beans to a lab to measure the amount of simple sugars. They found in order to provide 50 grams of simple sugars, they needed 72 grams of carbs, and they found that the amount of simple sugars in every batch of 28 jelly beans differed, meaning that it's hard to accurately recommend a number of jelly beans to match the glucola drink because from bean to bean, you're going to have a different amount of sugar in each bean. So a lot of people tell me they're interested in food-based or candy-based tests, but it's important to realize that there are different kinds of sugars and they don't all have the same effect on blood sugar levels. The official glucose tests were designed specifically for use with glucose, also called dextrose. So when you take the test with other kinds of sugar or with glucose in combination with fats and proteins, which you would see in like cake or candy bars or other sweet foods, could alter the results because fats and proteins may affect how your blood sugar spikes after you eat the food. This means that someone who has true actual GDM might not get the positive result on the test if they take the sugar in the form of candy or juice, which could result in a misdiagnosis. Also, candy alternatives have only been examined in research for the 50-gram glucola. They've not compared them in terms of how good are they at actually diagnosing GDM. They haven't compared them to the diagnostic tests. So people with positive tests with the candy in these studies had to follow up with the OGTT to test for GDM. We hear a lot of people are saying that they object to drinking the standard glucose beverage because of the additives, such as the dyes and preservatives and flavorings. We talked with a registered dietitian who is a specialist in gestational diabetes, Lily Nichols. She's the author of Real Food for Gestational Diabetes. She said if someone is absolutely opposed to drinking the glucola, you can actually buy dextrose, and you could measure out the equivalent grams of dextrose and drink it dissolved in 8 ounces of water. So glucose is the name given for sugar in blood, and dextrose is the name given to glucose that comes from corn and other foods. And you can buy dextrose in many places, including online and in local food stores. There was no evidence in the literature, however, to support this option, but some providers might recommend it over candy or juice for people who otherwise would decline to be screened or tested because they personally oppose the glucola and won't drink it. So I do hate to be the bearer of bad news, but the research on alternatives like food and candy alternatives is very limited at this time. We don't have high quality evidence that eating candy or taking glucose in food will correctly identify people with GDM. A couple other alternatives we talk about in the signature article include the fasting blood sugar test and home blood sugar monitoring. Screening by just doing a fasting blood sugar test would be quick, cheap, and could help you avoid side effects because there are side effects to the glucola drink. However, researchers at this time are still uncertain about using fasting plasma glucose as a GDM screening test. And you can read more about the research on that in our signature article. Another alternative could be for people to monitor their blood sugar levels at home and discuss the results with their care provider. This is a controversial way to screen for GDM, and we did not find any evidence on this. But we talk about the methods that some people are using in the signature article. This is a really hard topic. I mean, it's obviously controversial because we don't know the best way to screen and identify GDM, but it's also an uncomfortable test. There are side effects to the glucose solutions used in testing for GDM. In the Cochrane review by Farrar, 3 of the 7 studies reported side effects. Side effects of the glucose drink included bloating, pain, nausea, headache, dizziness, tiredness, and vomiting. And sometimes the side effects can be so severe that people can't finish the screening test or the diagnostic test. There's a large observational study from the United Arab Emirates published by Agarwal in 2004. They followed more than 5,000 pregnant women who took the 3-hour 100-gram OGTT, and they found that 503 participants, or 10%, were not able to finish the test because of side effects, and vomiting was the most common reason for not being able to finish the test, with more than 8% of women in the study vomiting due to the test. So the fact that there can be side effects that, such as vomiting, that make it impossible for you to finish the test for some people makes it seem clear to me that we need more research on alternatives, especially for those people who would otherwise decline the test or who can't take it because of the side effects. So as you can see, there's a lot of controversy, there's a lot of discussion and research and conversations going on about the best way to identify gestational diabetes. One thing we do know is that actually treating gestational diabetes can improve outcomes. A recent Cochrane review, again by Dr. Farrar, looked at 42 trials, 2 of which were very large and very high quality, where they looked at treatment for gestational diabetes compared to no treatment. And treatment typically covered what I would call a bundle of care, where they had exercise and nutrition counseling as the first line of action, followed by medication if values are not meeting the targets. The meta-analysis by Dr. Farrar found that bundles of care treating gestational diabetes that way did cut the risk of large birth weight in half. So it brings it back down to the risk that someone without gestational diabetes would have. It also cut the risk of shoulder dystocia by 60%. And in 2 of the trials, mothers reported higher quality of life after treatment for GDM. So the bottom line is that GDM is a true condition, and treating GDM does improve birth outcomes. There is widespread agreement that we should identify GDM. However, researchers and organizations disagree about the best way to screen and diagnose GDM. ACOG in the US prefers the two-part method that includes a screening test, frequently the glucola drink, and then if positive, you go on to take a diagnostic test. However, most other countries and organizations prefer a one-part method where everybody receives the one-part diagnostic test. I think it's also important to point out that with the two-part screening and diagnostic method used in the US, cutoffs for GDM can vary by hospital. So each hospital picks what their cutoffs are going to be. So when you get your results, it's helpful to obtain the actual numbers. Don't settle for a statement that said you passed or failed the test. Get the actual numbers on your test and compare them to the tables in our signature article so you can get a better result for where your results fall on the spectrum. Because remember, there's really no such thing as a true cutoff of yes, this is gestational diabetes and no, this isn't, because it exists on a continuum. And even if you don't technically have gestational diabetes according to where your results fell with your hospital, you might be just below the cutoff where you could still experience health effects if you don't manage your nutrition appropriately. And then finally, when we talk about alternatives, the evidence on alternatives to glucola and the standard glucose solution is very limited at this time. We don't know if getting a sugar boost from candy, juice, or food can screen for GDM as well as the standard glucose drink does. We need more research on using the fasting glucose test to screen, and we need more evidence on the home monitoring for screening, as well as alternative methods such as using dextrose dissolved in water. I know this can be a stressful topic because receiving a diagnosis of GDM can be stressful for most people. However, I do want to encourage you that the benefits for people who do test positive are that you can uncover the potential for health problems before they become a real problem and take action to improve your health and birth outcomes. I want to give a shout out to our reviewers for this article. First of all, Anna Bertoni, who co-authored this article with me. Thank you, Anna, for all the hard work you did on this. This was an incredibly technically difficult article to write. Also, I'd like to extend our gratitude to Dr. Diane Farrar, Dr. Shannon Vogt, Lily Nichols, and Dr. Jasana Cooper. Also, we had a couple of faculty members from Tufts Medical Center in Boston who were so helpful in giving us feedback on the section about what is gestational diabetes at the beginning of the article. And I also want to give a shout out to Kristen Pascucci, who always does such a brilliant job editing our articles and making sure that they're readable for the public. So again, you can find the full-length article at evidencebasedbirth.com/diagnosing GDM. Thanks everyone, and I hope you found this helpful.